Meningitis. A boy was admitted to the hospital after having experienced tonic-clonic seizures multiple times in the last 24 hours, along with high-grade fever, vomiting, and decreased oral acceptance. When the doctor flexed his hip and knee at a 90-degree angle and then tried to extend the knee subsequently, the patient was seen to experience pain, leading to resistance. This observation is a positive Kernig's sign. Next, he flexes the patient's neck and notices that it elicits a flexon at the hip and knees as a reflex. This observation is called a positive Brudzinski's neck sign, which indicates that the patient is suffering from neck rigidity. He also showed photophobia, phonophobia, altered sensorium, skin rashes. Based on the observation of these symptoms, the doctors suspected this to be a condition called meningitis. Meninges. In the entire central nervous system, the brain, medulla, and the spinal cord are enclosed in three membranes. They are the outer dura mater, the middle arachnoid mater, and the inner pia mater. Together, they are called meninges. These membranes are separated by the subdural space and the subarachnoid space. An inflammation of the meninges is a condition referred to as meningitis. In order to identify the cause of meningitis, a procedure called spinal tap or lumbar puncture is performed to collect the patient's cerebrospinal fluid. The sample is collected into 3 sterile containers for immediate processing, one each for pathological analysis, biochemical analysis, and microbiological analysis. If the cerebrospinal fluid is turbid, it is due to the presence of pus cells, which are basically a buildup of dead white blood cells produced during infection. Due to the involvement of pus cells, the condition is named Biogenic meningitis. It is seen to result from infection by bacteria. Biogenic meningitis. Common bacteria that cause meningitis are Group B Streptococcus, Listeria monocytogenes, Escherichia coli, Klebsiella species, Streptococcus pneumoniae, that is pneumococcus, Haemophilus influenzae type B, Staphylococcus aureus, and Neisseria meningitidis, that is meningococcus. Neisseria meningitidis is a Diplococcus bacterium called meningococcus. The bacteria are transmitted through respiratory droplets The bacteria travel through respiratory droplets along the respiratory tract, initially till the nasopharynx. They colonize the mucosa of the nasopharynx. They invade the cells and are endocytosed by the mucosal cells. They cross the mucosal barrier and enter the blood. The capsule is made up of polysaccharide antigens. Based on these polysaccharide antigens, Neisseria meningitidis bacteria are further classified into over 13 serogroups. Serogroups A, B, C, W135, X and Y have been seen to most commonly cause meningitis. The bacterial capsule is the main virulence factor because it helps the bacterial cells survive from phagocytes in the blood. In circulation, the cells are capable of adhering to the vascular endothelial cells and proliferation. They cross the blood-brain barrier. They now enter the central nervous system, which is devoid of antibodies, complement or opsonic proteins. Astrocytes phagocytose the bacterial cells. This process releases cytokines. Macrophages may also enter the CNS from the blood. They also phagocytose bacteria. This also releases cytokines. This gradient of cytokines attract the neutrophils in the blood to enter the CNS. The neutrophils pass through the wall of the blood vessel without rupturing it. This process is called diapedesis. The increase in the count of neutrophils in the cerebrospinal fluid is known as pleocytosis. These neutrophils also proceed to phagocytose some bacteria, releasing more cytokines. In response, free radicals like reactive oxygen species, nitrous oxide, and peroxynitrite are generated. These attack the vascular endothelial cells and damage them. This increases vascular permeability and allows RBCs to leak out of the blood vessel. The bleeding in turn causes edema and, subsequently, the inflammation of the meninges, that is, meningitis. Aseptic meningitis. We know that in cases of bacterial meningitis, the CSF collected will appear turbid due to the presence of pus cells. Understandably, if there are no pus cells in the sample, the CSF will appear clear. This type of meningitis is known as aseptic meningitis and can be caused by a host of different organisms. Some bacteria, like Leptospira interrogans and Treponema pallidum, can cause aseptic meningitis. Meningitis caused by Mycobacterium tuberculosis is called tubercular meningitis. Fungi such as Cryptococcus, Candida species, and protozoa like Acanthamoeba, Naegleria, Toxoplasma gondii are capable of causing meningitis. However, the most common pathogens of aseptic meningitis are viruses. These viruses may be enteroviruses, herpes simplex viruses, HSV2 and HSV1, varicella zoster virus, VZV, human immunodeficiency virus, HIV, Epstein-Barr virus, EBV. Currently, more than 85% of viral meningitis are caused by non-polio enteroviruses like Coxsackie viruses. Most enteroviruses are transmitted from mother to newborn through contact with maternal secretions during delivery, blood, or upper respiratory tract secretions. The viral particles spread hematogenously. They may be transported through infected leukocytes like macrophages. These macrophages are able to cross the wall of the blood vessel by diapedesis. The viruses infect vascular endothelial cells and multiply inside them. Eventually, the host cell is lysed, and the viruses are released into the central nervous system. Astrocytes phagocytose the viral particles. This process releases inflammatory cytokines interleukin IL-1 beta, IL-6, and tumor necrosis factor TNF-alpha. Macrophages that may have entered from the blood also phagocytose viral particles. They release cytokines. During viral infections, T lymphocytes are recruited. They cross the wall of the blood vessel by diapedesis and infiltrate the central nervous system. This gradient of cytokines attract the neutrophils in the blood to enter the CNS. In response, free radicals like reactive oxygen species, nitrous oxide, and peroxynitrite are generated. These attack the vascular endothelial cells and damage them. This increases vascular permeability and allows RBCs to leak out of the blood vessel. The bleeding in turn causes edema and, subsequently, the inflammation of the meninges, that is, meningitis. Laboratory diagnosis of meningitis. Let us understand the other tests performed for diagnosis. Microbiological analysis. One portion of the CSF is centrifuged. The deposit is strained by gram stain and examined under the microscope to identify the bacteria. Neisseria is a gram-negative coccus. Nigrosin stain is used for detecting capsule of Cryptococcus neoformans, and Ziehl-Neelsen stain will reveal acid-fast bacilli. This is used to identify Mycobacterium tuberculosis. From the centrifuge sample, the supernatant fluid is used for latex agglutination. The sample is mixed with latex beads that are coated with a specific antibody. If the suspected antigen is present, the antigen will bind to the antibody on the latex bead. This can be observed by the latex beads clumping together, that is, agglutination. A second portion of the CSF sample is used to inoculate cultures on different media, such as blood agar. The cultures are incubated at 37 degrees Celsius. The colony morphology is studied. For example, N. meningitidis colonies are gray and unpigmented on a blood agar plate and appear round, smooth, moist, glistening, and convex with a clearly defined edge. A colony is isolated and gram staining is performed to microscopically identify the bacteria. A third portion is kept at 37 degrees Celsius in an incubator overnight. On allowing the CSF to stand, if a fibrin web or cobweb is formed, it can be confirmed as a case of tubercular meningitis caused by Mycobacterium tuberculosis. Pathological analysis. CSF is put on a slide and under microscope to count the number of cells. Normal CSF has 0 to 5 lymphocytes per cubic millimeter and generally no neutrophils. During a bacterial infection, neutrophil count will be high. It ranges between 1000 to 20,000 cells per cubic millimeter. However, if the pathogen is Mycobacterium tuberculosis, the lymphocyte count will be high, ranging from 50 to 500 cells per cubic millimeter. In viral and fungal meningitis, lymphocyte count will be high, ranging from 10 to 500 per cubic millimeter. Biochemical tests are performed to determine the glucose concentration and protein concentration in the CSF. The normal glucose concentration is 50 to 80 milligrams per deciliter, which is what is observed in viral meningitis. In bacterial, fungal and tubercular meningitis, glucose concentration will be less than 45 milligrams per deciliter. The protein concentration is highly elevated in bacterial and tubercular meningitis, 80 to 600 milligrams per deciliter, while it will be moderately elevated in viral and fungal meningitis, 60 to 80 milligrams per deciliter. Normal CSF has 15 to 40 milligrams of protein per deciliter.